Thank you all for joining us for this panel on Can Medicine Become More Equitable? I would like to introduce my panelists here. First, we have Linda Villarosa. Linda is a contributing writer at the New York Times Magazine and author of the newly published book, Under the Skin, The Hidden Toll of Racism on American Lives and on the Health of Our Nation. Next, we have Dr. Paula Johnson. Dr. Paula Johnson is president of Wellesley College and a cardiologist. And then we have Dr. Carolina Reyes, who is maternal fetal medicine specialist at UC Davis School of Medicine. So to kind of start off this conversation, I want to quote from an article that my stat colleague Usha Lee McFarling wrote on unequal treatment. So she starts her story by saying, the 764-page report minces no words about the inequality rife throughout medical care. Racial and ethnic minorities experience a lower quality of health services and are less likely to receive even routine medical procedures than are white Americans. Those words might have been written recently amid a pandemic that has disproportionately sickened and killed people of color. In fact, they were written 2 decades ago. So, Carolina, you were an author of that report. Tell us, has progress been made in the past 20 years since it's been published?
I'd like to think that there's been some progress, but clearly not enough. We have a ways to go. I think at the time when, we have to understand that the Unequal Treatment report was really mandated by Congress. So there was this political will from a public outcry that you have 400 articles already in the literature describing the disparities in healthcare delivery, that patients are treated differently based on culture and based on race. And so it didn't come from the medical community, it really came from public will. And that report, we thought, was just going to be an epiphany for everyone. I think that understanding that, yes, we treat patients differently as a physician was really a surprise to me, even as a young physician then, because I thought, well, that's not how we're trained, right? But clearly there are decisions that one makes by the assumptions that they make by just seeing the patient as opposed to listening and understanding the patient. Have we made a difference? I think that at the national level, there are certain changes that have been made to try to track this, right? So AHRQ came out with the Healthcare Disparities Report on looking at differences in healthcare, which we didn't have those kind of measures. And I think that that has helped us look at it. But at the institutional level and at the physician-patient level, we haven't integrated the kind of training, the number of underrepresented minorities that really should be at the table, providing this care, et cetera. I think what that report showed was where you live matters, who's providing your care matters in terms of the quality of care. And so I do think that there are some changes, but clearly not enough. And now that I think the big elephant in the room is, right, there are differences, and we see this not only with striking differences now in how patients had to handle COVID or these kinds of epidemics, but we clearly see that there's a lot of room for improvement.
Thank you for that. I'd love to direct the question to Paula now. In terms of the past 20 years in health equity, since that report has been done, have we been making progress? And, what progress is there still yet to be made?
Well, I think just building on Carolina's really fabulous opening, yes, we've made progress. We're talking about these issues, I think, in a more advanced way. I remember as an I'm a clinical epidemiologist, so I'm an investigator, I'm a physician scientist, and in the early days, in the 90s, early in my career, when we were doing research focused on, for me, it was the intersection of sex and race and ethnicity. The word racism was nowhere to be found. And I think that we've evolved to having a fuller understanding of the depth of what is behind the inequities. So I think that that's an advancement. What I haven't seen necessarily are, and I think this is building on what you said, are the systems that can build on that knowledge. Now, you know, understanding that we've got a tremendously inequitable society, so we're going to have to attack this on all levels. But if we talk about the healthcare delivery system, we have really not seen what we have learned, implemented, and just to say, we saw that up close and personal through COVID, which was an absolute disaster. And what was frightening was that even at the beginning of the pandemic, we did not even have the measurement, the data systems to really understand what was going on, who was being impacted, and where. And that's not even addressing some of the individual biases that we saw in care. I wrote an op-ed for CNN that talked about one of our alums, was a master's student, brilliant young woman living in Brooklyn, who, you know, went to the hospital 3 times and was told she had an asthma attack. And guess what happened that 3rd time when she came? She was admitted, intubated, and she died. So I think that this is the kind of thing, and it's not just those who are underprivileged or poor. It is, and Linda, your work just so brilliantly tells those stories.
Yes.
Thank you.
Thank you. And I'd love to, direct it to Linda now. In your coverage, especially looking at how health equity has received more focus in the past 20 years, I'd love to direct the same question. What kind of progress has happened through your lens as a reporter?
Well, first of all, thank you for both of your work. I remember when Unequal Treatment came out, and it was so massive, and I remember just devouring it, because there we finally had the evidence and the proof. But so much of my work is about that, plus narratives of people. And the people stories are the ones that kind of touch my heart so much. But even in the evidence, when you're looking at the story, when you're looking at the research, 483 different studies, the one that struck me the hardest, and I remember closing my eyes and thinking about this, was the one on amputation and diabetes. So even when the health insurance was equal and the severity of diabetes was equal, Black people were still much more likely to have amputation. And I kept thinking to myself, well, I don't think providers go into service to harm people. But someone made a decision more often to cut off the Black person's leg. And that is debilitating for someone. And so even in the research, there are stories, health is people. And so I keep hearing the stories, even, that was 20 years ago, and just keep hearing them. And I'm on a book tour now, and it's intense to have people stand up and say their stories, their personal stories. And it's people coming to a book signing who could afford a $30 book.
Right.
So there's still something clearly going on.
Yeah.
Certainly. Thank you for that. And I'd like to let the audience know that, we want this to really be a dialogue, a conversation. So if you have questions, feel free to raise your hand and we'll make sure someone with a microphone gets to you. So I want to start with, direct my next question to you, Linda. Roe versus Wade was just overturned today. It's really tragic news for maternal health care. I would like to ask you a bit about, 20 years ago we had Unequal Treatment come out. Roe versus Wade was there. Roe versus Wade has been around since, I believe, the 70s and such, and now we're entering an era where it has been overturned. What does that mean for health disparities, for health equity in maternal health? We have a maternal health crisis in this country.
Well, I think I was, today, and even when the decision was leaked, people were saying, oh my God, we're going to be in a Handmaid's Tale situation. And Black women were like, we have been in a Handmaid's Tale situation. We know this. We know what it's like. And I was thinking that this decision is, it's specific to Mississippi. Mississippi is the poorest state in the country. If you take a lens over the states that have the trigger law, that means once Roe versus Wade is overturned, then they go right into a anti-abortion situation. The overlay is the South. That's where most Black people live. These are the poorest states. These are the states where healthcare is already in trouble and is hurting. Ironically, it's also the state where Fannie Lou Hamer is from. Fannie Lou Hamer had what's called a Mississippi appendectomy. That means that she was sterilized against her will when she went into the hospital system for something else. So there is a through line to this. There's a through line to being Black and other women of color. There's a through line to being poor. And we are the ones that are going to suffer the most. But it's also, we're the ones who can lead us out of this because we were the ones who already know what's going on, and that this abortion isn't a single issue.
Right.
Abortion is in the larger picture of reproductive health and reproductive justice.
Thank you. And Carolina, I would love to pose the same question to you.
I think what was different 20 years ago, we didn't have the Affordable Care Act. And so clearly now there is more access to care early in the process. And I think that we're excited about that because it helps us prevent many of these conditions that lead to maternal mortality or these chronic illnesses are preventable. And so there's a lot of hope that women can enter earlier. What else is different is that there were better access to contraception, medical sort of use of treatment early in the pregnancy. So identifying pregnancy early, earlier access to care has, to me, always been really sentinel to helping then help us help patients. So clearly that is different, right? And we don't want to lose that. That's still a battle, but clearly more women have access to care and earlier on in their lives. I think more women have access to information, right, compared to 20 years ago, and come in a lot more informed and really a little bit more organized. I do sit on a maternal mortality review committee for the state of California. We reviewed 5 years of maternal mortality 10 years ago to look at what we can do differently in hospital systems. And from that, there were things that we could do differently in terms of addressing some of the acute conditions like postpartum hemorrhage and dealing with hypertension disorders earlier in the process. And certainly in states that integrated that evidence-based practice, we've seen that improvement in maternal mortality. We've just reviewed another set of 5 years saying, okay, where are we now? And clearly there's still room for improvement. But as I mentioned, regional, in terms of region and where you receive care, it matters.
Can I say that
please do.
I was really impressed what you did in California, and to see that drop in maternal mortality, but the racial disparity didn't change.
No.
But now, I like to call out, because I'm a journalist and mean, and so, but I'm impressed that you're including anti-racism, anti-implicit bias training in, for healthcare providers.
We didn't ask that question 10 years ago. When we reviewed these cases now, and this is like the largest, I think, this was for postpartum hemorrhage, really the largest cohort, because it doesn't occur that often, because when we talk about maternal mortality, it's like per 100,000. And so, yes, we included those questions. Was there any evidence of structural racism or certainly physician bias? And those are harder to decipher, but at least we were trying to answer those questions.
Thank you for that. And Paula, I would love to kind of build off of what Carolina said about anti-racism and racism. And you brought this up in your opening a bit about, we now use the word racism. Speak to us a bit about why is that so important that we name it, that we use the word racism or structural racism in healthcare?
It's because we're in the United States of America. And, it is part of the fabric of our country, and therefore inequalities, inequities foundationally have a rooting in racism. And I think there's one thing where we're now having a quote unquote reckoning with it. The question is, how do we take that reckoning and actually operationalize it in order to work against it? And I think that is the big question that we all have to answer. And we do it in different ways. I do it in ways as a college president. I mean, Linda's doing it in ways as a journalist, and Carolina in her work as a leading physician and involved in policy. But it's got to be at the crux of all of our work.
Thank you for that. Linda, you have your book coming out. You talk about forced sterilization without consent. Writing that book, doing that reporting, going forward, do you have any I don't know if the right word is optimism, but does it just hurt your soul hearing those stories going forward? And how do you take those stories and continue to do the work that you're doing? Are you optimistic that things will change?
I really love, I'm very, very passionate about this, and I don't get upset. I just get mad, and then I get more impassioned. And I love to tell the stories of people because that's what gets people reading. What my editor does is she looks at my stories, and I'm heavy on evidence. And then I can see that she's going to cut something because she's bored. And this is like too complicated. Just tell the story of the person now, because you want to hold on to the readers and get them engaged in the storytelling. So I really love that. I really feel honored that people share their stories with me. And also when I'm talking to audiences, and I love when people stand up and said, this thing happened to me. I have optimism always. And one of the things is I see medical students that are really engaged in social justice thinking. I see them trying to saying, I want to do something differently. I see the state of California saying, well, we didn't incorporate that, the anti-racism part in the first round, but now we're changing. And I think changing your mind is really important for us because it's hard. It's hard to admit that you maybe didn't do something right or you did something wrong, and then to fix it. And I love that.
Right. I'll go to Carolina first.
Okay. Just to add to the information around sterilization, certainly in California, as we know, at LA County USC, which is where I trained, and right before I got there, it was really an outcry from the community about sterilization without consent. And again, it draws on many of these issues around racism and how people are treated differently, and much of it is around consent. So at that time, these were legends in obstetrics and gynecology, right? Forwarding progress in terms of how to do things better. But yet, when it came to consenting a patient, our then top faculty would basically just ask the patient in broken Spanish, no more babies, right? And they would say, no, I don't want any more babies, and then they would recognize if they were sterilized. So, but the outcry really came from the community. And that then led to the legal system entering, right? Because that is medicine too, a practice of medicine in terms of helping alter what we do in practice. And now women have to be consented in the language of their choice with a written consent in the language of their choice a month before they actually deliver. And certainly if any tubal ligation is performed for anyone that is, will be reimbursed through federal government, through Medi-Cal usually or Medicaid, that's a practice, not necessarily private insurance. Private insurance, they can just make that decision at that moment. But I think what is different too, and I should mention, are the culturally linguistically appropriate standards. So they were sort of adopted a little before the Unequal Treatment report came out, but they were available. And I think that's where there's low-hanging fruit, in that we're too complacent in how we manage patients. I do feel we don't listen enough, and we certainly do not, we need to do a better job at consenting them in the language of their choice with the written consent in the language of their choice. And I see that in California. We have a lot of room for improvement there.
Consent is so important. I think Paula had a quick.
Yeah, no, I was going to really talk about a very different area, which is that as we think about care, there's the care that we provide as physicians to individual patients, and how does that get influenced? And then there are some of the structural ways in which healthcare is provided that really can connect with some of the ways that structural racism has played out in communities. And what I mean by that is, and there are different models for this. Way back when I chaired the Boston Public Health Commission, we had a program where data on asthma, and there's a much higher rate of childhood and adult asthma in Black communities, where yes, you worked in order to provide culturally appropriate care, get people in, children in as quickly as possible, have them have the appropriate medications, teaching, all of that. But what was different was that the data were then connected with the Public Health Commission, which was in charge of housing. And what we ended up seeing in that was that you began to see clusters of where children and adults were being readmitted. And through that work, we were actually able to address the housing issues that were really at the core of some of the disparity, not all. So it just goes to say that these issues have to be addressed at a number of levels, and our healthcare delivery system must connect with other systems in order for us to really get underneath some of these issues.
Thank you. Linda, I think you wanted to add.
Oh, I was going to say something back to the, no, that's okay. The sterilization. In only 3 states have paid back women and men who were sterilized against their will or without consent. Virginia and North Carolina had programs where they gave like $25,000 per person. California is in the midst of that, and some of the sterilizations that happened there were incarcerated women.
Yes.
And it's, you know, I'm in New York, okay, but I am impressed that California is really trying to make a difference. And when I wrote about it, I just called it reparations, because there's always this wrestling over, oh my God, how do we do reparations? Who do we give, how do we figure it out? I was like, well, this is easy. Find people who were sterilized without their consent or against their will and pay them back for taking away their fertility.
Thank you for that. Oh, go right ahead.
In terms of the structural racism, because I think that this is where, again, it takes more than just within institutions to change themselves. But clearly now we do have more women in healthcare, and we have more women in leadership positions. I think that makes a huge difference. But we haven't made too much of a difference in terms of the number of faculty that are of underrepresented minorities throughout those 20 years. It's really been pretty stagnant. And that's appalling, because again, it's about trying to provide care to individuals that are like themselves, you know, that can understand individuals. And so I do think there's tremendous room for improvement in academic medicine in terms of helping support underrepresented minorities to continue in what I used to think were the arenas where priorities were determined. I do think that at the C-suite levels and at the board levels for our health systems now that really drive healthcare, we need to push to have more underrepresented minorities at those positions, because the policies that are made at those levels have consequences sometimes that can lead to differences in the way care is provided.
Thank you for that. And I want to jump on something that Linda said. You know, we were just talking about the use of the word racism in medicine and how that is important to call it out what it is. You brought up another R word, reparations. What is owed to people who have been wronged by the medical system, by the medical establishment, especially people of color, and in particular, Black Americans. I mean, your book, and we've spoken about this on my podcast about you know, sterilizations and such. I would just like to kind of pose to the panel, will there be a time where reparations is used in medicine and is used freely, or is used openly, or is used with strength?
Well, I'm going to admit that I had trouble even with racism. And the subtitle of my book used to be Race, Inequality, and the Health of Our Nation. And then the cover was done. And then I started thinking, why am I calling it race? In the book, I'm calling it racism. But on the cover, I felt like it was, I felt mixed, and I didn't want people who were doing their real best in healthcare, and doctors, nurses, midwives, are they gonna think I'm thinking that they're racist? And then I thought, okay, stop, just do it. And it was interesting because when in one of the earlier panels, we were talking about the George Floyd racial reckoning, and the panel said this really amazing thing. She said, oh yeah, that when everyone else in the country realized, discovered racism. And so I thought, you know, other people are saying it, the CDC is saying it, the AMA is saying it, I need to say it on the cover of the book. And then I also didn't use remuneration, talking about paying back people who had been sterilized. I used reparations, and you could imagine at the New York Times, the copy editor was like, can we call it a kind of reparation? I was like, okay, as long as we have the word. because we were being cautious. So that's the new word we're cautious with.
Right. So we're not there yet, but.
Not quite.
I'd love to take this opportunity to open it up to questions here. Again, I would love for this to be a dialogue. If you have any questions kind of for our panelists, go right ahead. Anyone in particular? Just a scratch back there. So building off of, the George Floyd protest and this wave of money, funding towards health equity, are you scared that it might dry up, that people will stop caring about health equity in many ways like they did before what happened with George Floyd?
I think that that's really the message. I do feel that over the 20 years, there was a level of complacency. It's almost like disparities existed and we just accepted them. And we recognize that there's so many ways that we can prevent. As I mentioned, much of the consequences of these disparities are preventable. And so I think, to me, the message, the takeaway is not to be complacent, that the public has a lot of say in terms of how institutions carry out their work. It takes a while, but they have a lot of say. And as I mentioned, in terms of some of the larger systemic changes, it came from public outcry. So now with Roe versus Wade being overturned, it's a sad day. I am terrified. I remember the days where in residency we had wards where we had to treat women because they had botched abortions. It was something that was not in my brain before, but it came back. And so we know that those disparities are going to exist. Disparities are going to be worse. We know this because people are going to be afraid to come in for care. Providers are going to be afraid to practice in states where they're intimidated and may undergo litigation. So in those states, it's going to be more difficult. And it will only change if there's public outcry.
Thank you. So what can be done now? One thing I love to leave groups like this with after coming to a panel are action steps. When everyone flies home from Aspen, what can they do, whether they be physicians, whether they work in the pharmaceutical industry, or whether they just work in some capacity in healthcare? What can people do to promote health equity, to close these health disparity gaps? I'd love to hear. I'll start with you, Paula.
I think that one of the things we really need to do more systemically is understand the data. And, I bet many of you in this room, I was on an earlier panel where I said the same thing, I bet many of you in this room are either on boards or involved in different philanthropic activities in which you do have the power to ask the question. So in hospitals, for example, are data routinely stratified by sex and race and ethnicity? Because honestly, if you really don't, every day at the highest levels, and it gets back to Carolina, what you were saying in terms of who's asking the question, who's leading the charge, if you are not actually having it in front of you every day, if you are guessing at what the disparities are, you really are not going to be serious about answering or dealing with them on a fundamental level. And so I really think that we have to begin by saying, we know this exists, but now we are going to routinely collect and report data that we have to be then held accountable for. And that goes almost in anything. It's not just in healthcare. It is in everything. It's for me at a college level, how do I understand the experiences of our faculty, of our students, of our staff? And if you don't ask the question, we are never going to get to the answer.
There definitely, there are many things that are changing now. The question is, can they be sustained, right? So certainly within healthcare foundations, when it comes to funding, we basically are asking those that are being funded, do you have a mission statement on race, ethnicity, and equity and inclusion? How many of your directors are of underrepresented minorities? Asking those questions. I think that there was a change and some of this is anecdotal, but it was research done by David Carlisle, who is now dean at, or president at Charles Drew University, where he said at the federal level, the NIH grants in terms of asking data of their universities, ask data on race, ethnic stratification, not just of their faculty, but of their students. And he noticed that there was a difference in terms of those institutions that had better data on that had more funding. So in other words, I think that there are ways to require at the systemic level, having this always in our face, you know. So how many directors now, right? How many medical students are you training? How many nurses are you training that are underrepresented minorities? And where are they practicing? And having that data first and foremost, having the implicit bias training now, I think is much more institutionalized. 20 years ago, there was a whole section in the Unequal Treatment Report on implicit bias. And it wasn't a question of whether it existed, it was a question of how do you train physicians? How do you train providers? So now I see at the board levels, the different specialties, they're requiring some of this training. We're requiring it at our universities. And so it just has to, it takes it at every level, but we have to sustain it.
Can I just add one thing to this? Because I think as we talk about the diversity of our workforce and at the highest levels in academic medicine, in which it is, the numbers have stayed remarkably flat.
Yes.
One of the issues that we have not gotten serious about is sexual harassment. Yes. And I co-chaired the National Academies. It was a combination of the National Academies of Science, Engineering, and Medicine, the first evidence-based report on sexual harassment in academic STEM. It was published about a little over 4 years ago. And what we found was that sexual harassment in academic medicine is some of the highest rates in all of the areas, only second to the military. And the experience of women of color is far worse than Caucasian women. And we don't talk about this. And in fact, I think some of the assumptions are that women of color don't experience sexual harassment. This is adding, this unspoken, unaddressed issue is also adding to dropout of people from the dropout of women, not only from science, but from academia. And if we think about that pipeline, we have to continue that pipeline, and this is a very important factor that really needs to be addressed institutionally.
Yes, Paula, thank you so much. Questions, go right ahead. And right, we have a microphone coming, and if there's someone who could help us with Linda's mic over here from the staff.
It still works, but
Oh, is it? Okay, then we're good.
Drop it.
Go right ahead.
Hi, everyone. Really fantastic discussion. My name is Nicola Davis. I'm the Chief Pop Health Officer at New York City Health and Hospitals. So my question is around thinking about the embedded clinical algorithms and the structural racism that we have in medicine as a result of algorithms. So I'm sure you're familiar with VBAC as well as how we calculate kidney function. And so I'd like to kind of hear your thoughts as to how do we communicate. Our health system is working on correcting all of those things. And what are your thoughts on how do you communicate that to your public?
Great. I think I can answer some of this. I mean, clearly it affects women's health in our delivery system in terms of, again, trying to have information in front of you that is as much evidence-based, but yet that data is not reflective of underrepresented minorities in that data. And yet that data informs these algorithms. I think clearly it's understood in medicine now that there isn't a place for race as a factor in terms of, certainly for us, as we have formulas to look at what is the success rate for of vaginal birth after a cesarean, a VBAC. We no longer use race as an indicator. It used to lower the rate, and among African American population, without really a lot of data, I think we just took it for granted. And but it was part of the formula that if you're African American, it lowered your risk, and therefore women, based on that data, would decide to just have another cesarean as opposed to a vaginal birth after cesarean, which is lower risk. So we no longer have that in our place. But there are things that we need to be changing now that we have to be very mindful of, and that is the information that goes into our artificial intelligence that provides us some data. We're doing it now. I mean, with cervical cancer, we've just made changes federally, right, on the use of not using a pap smear, but only using HPV as a screening tool, where there's a high percentage of cervical cancer that is not related to HPV. And we know that there's a high percentage, a disproportionate percentage, of those that are affected with cervical cancer, African Americans and Latino population. Again, underrepresented minorities. They are not in the data, but yet the data was utilized to create these now evidence-based practices that say it's okay to only do a pap smear every 5 years. And we're saying that's not our population. So we are now still actively creating this, and what the CDC and others have said, yes, we recognize those populations were not represented in this data, but we're assuming it's the same. So this is where we're still actively making these kind of policy decisions that will affect clinical practice. And so we have to be extremely careful and asking the question, what data is going in to inform our evidence-based practices?
Thank you. I saw another question right over here.
Hi, I'm Alan Weil, Editor-in-Chief of Health Affairs. Every social justice movement faces backlash as people with power seek to hold on to it, and it's often, the backlash often comes in the form of generating fear of loss among people in the majority. Linda, you mentioned what I would call self-censorship around your title. I thought that was a really telling story, but I wonder if any of you have actually experienced more of an external pressure. We often surround ourselves by like-minded people, but not everyone is. I wonder if you could tell us what you faced as backlash and what your response has been to it, any of you.
I'll start. I got invited to a hospital in a city in the Midwest to take part in the grand rounds, the OBGYN grand rounds. So there were 12 doctors and me, and they had just read my article on maternal and infant mortality. So I was there to talk about it and answer questions. So the first question was from the chief, and he said, I don't understand why they let you into the labor and delivery room. And I said, that was your takeaway, not what happened to that, wow, the person? Why was I there? And then the rest, and this was not long ago, then the rest of was an hour of torture for me. It was all these myths. The first, that there was a genetic problem. How do you know it's not a genetic problem? I'm like, this isn't a genetic problem. Read the story carefully. Then it was, someone raised her hand and she said, do you think it has something to do with nutrition and diet? I said, for this mother, I didn't say anything about her nutrition and diet, which I know to be fine, but it wasn't that. And then finally, the last person said, well, what we see in our hospital, where there was a large population of immigrant women and refugees, is that the women from Africa have a kind of a kinship circle that Black American women don't have. I didn't know what to say because this is crazy. Mm-hmm. So finally, at the end, I believe in the concept of weathering, where if you have repeated stress, you lose years off your life. I just looked at my watch and thought, I just lost a month here of my life because I was so mad. And what I said at the end was, what I notice here is that you do have a large population of African women, but they are soon going to be African American women. And they are, some of them already are. And if you continue to treat them like this and to come in with these myths about kinship, what is that, genetics? And the other thing I said was, what I see in this room is 13 people. 12 are white. and I don't work here. And that was it. And then I left.
Wow. I would love to,
Probably
pose that question to the rest of the panelists.
You wanna
Or if I
answer
could
that?
add to that question, what is your advice for people who want to do this work, health equity work, very passionate about it, but are afraid of retribution?
I think there's no room for complacency anymore, honestly. I think that using terms like racism are now, I think that there is an understanding and a recognition, and there's room for it everywhere. As I mentioned, I like to think that anyone I work with has a mission statement about DEI and has measurable outcomes that we'd like to see are different in a short period of time. So for me, there isn't complacency anymore. It's just, it is a must. It's the way we will make improvements in healthcare. It's the way, for me, the whole work has been on how do we prevent conditions that are preventable. And this is a big part of it. What I appreciate from Dr. Johnson is that it's true that we now have more data on social determinants of health. And so, like I say, where you live matters. The policies that are made around where people live matters. And so there is room for everyone to have a role, whether it is in environmental health, whether it is in housing, et cetera. I think to me, all of that is the practice of medicine.
The reality, and again, I'm going to get back to academic medicine. I've spent over 30 years of my life. I was a professor of medicine at Harvard Medical School and a professor of epidemiology at the Harvard School of Public Health. And at the end of the day, when you are climbing the academic ladder, there is a fear. Because when you are one of only a few, I was the first Black person to be a professor at Brigham and Women's Hospital in their 100-year history. So you were, but you were there and there weren't others with you. So when you are thinking about, and there aren't enough of us at the highest levels to actually support and mentor. So I do think we have to make sure that our young people who are moving through that ladder are not only supported, but we figure out strategies of multiple mentors. We cannot allow those young people to only be reliant on one person. We have to make sure that they are involved in different programs. I'm going to name one, the Robert Wood Johnson Harold Amos Faculty Development Program, which is incredible because it not only provides you with outside mentors, but it also provides you with a series with colleagues. There are ways that we need to be really thinking hard about this because retribution comes in many subtle ways. And people then drop out and they wonder, oh, they just didn't cut it. They just couldn't make it. And frequently that is just not the case. So we have a lot of work to do in the academy, and it has to begin with supporting enough people so that we do reach the highest level, so that it's not just one or two or three of us, but that there are others who can be looked at to support them as they're coming up.
Thank you for that.
I wanted to add this organization called the Institute of Healing and Justice in Medicine. And sometimes social justice movements, or often, happen from the ground up. And these are 4 medical students who took a class in sort of racial health disparities and health equity and at Berkeley. And they are going to public health school at Berkeley. They're at UCSF for medical school. And they're in school. So they started this organization during the pandemic, and it was toward the abolition of biological race in medicine. And they wrote this beautiful, I call it a manifesto, and it's on their website, and it's so good. I was like, how did you 4 do this? And I said, how much money did you get from your colleges to help you? And they said $700. And at the same time, we said, for pizza? And it was for pizza. But these students have had, when they launched it in April 2020, they had something like 7,000 views of other medical students around the country talking about getting rid of this sort of, these old school genetic reasons and some of the myths that are still embedded in medical education and training. And I just am marveling at them. They did it with no money while in medical school, and they managed to, get it out through digital means and social media. And that is impressive. And I think just pay attention to them.
Go right ahead.
I wanted to give a good example. There are many examples on sort of experience with individuals who are well-intentioned, but are making bad decisions. I wanted to use the example of Paul Farmer, and I know there was a workshop really around his work on global health and the work that they were doing in Haiti around, at the time, HIV. And recognizing that there was medication, right, at that point, AZT, that was available, and multiple medications to help reduce resistance in HIV because it was rampant in Haiti. They found a way to have what we would call promotoras, but community health workers that they trained to ensure that these individuals were taking their actually, I think this was TB. This was, they did work on both HIV and TB, but this was tuberculosis. And they made the effort to make sure that these community health workers were seeing these patients daily, making sure they had their medication. So Paul Farmer and his group came to the US and was actually trying on a global level to say, this works. Brought together infectious disease specialists throughout the world at Harvard and saying, we can demonstrate that we can reduce the epidemic of tuberculosis resistance by making sure that people take their medication. And we've demonstrated. And the assumption was, by these infectious disease specialists, they didn't get the support. They didn't get the support from the global HIV, ID experts, because the assumption was these individuals are not going to take their medication, and they will just create more resistance, and that will be worse for the rest of the world. And again, to me, it's about complacency. Paul Farmer and his team did not accept that as enough, and said, we can demonstrate that this works, and then took it to World Health Organization, et cetera, and was able to demonstrate this, and I think it helped reduce our levels of TB-resistant type infections in the world.
Do we have any final questions? I'll go right here. Yeah.
Thank you. I just want to get back to your point, Nicholas, about what can we do, and to kind of feed off where Dr. Johnson left off. So I work in a large academic medical center in New York City, and it's like, so how do we move equity forward, and how do we sustain that, right? So I just want to, and sometimes this just happens, and I want everyone to understand this is not just the work of Black and brown people and those people who are marginalized. This is work that we all have to do. So, and sometimes people don't think that, and I'm sure you've been addressed, in ways that, well, what are you doing? And people, everyone, they want to appoint just Black and brown people to the issues, right? We have to fix the problem, right? And I think to answer your question specifically is that all leaders, and we do have to start with leaders, have to be held accountable. They have to come together. It's a collective effort, and we have to, and it has to be embedded in every aspect of what happens in an organization. It's not just something that one day you talk about equity over here. It has to be embedded and threaded through every single aspect of the organization, whether it's, as we're talking about, our students and our faculty, how they interact, all policies, practices. It's a very tedious, but you can be very strategic and direct and intentional about it to actually change an organization. And we have embarked on that at Mount Sinai Health System in a way that's very, very specific. But again, our leaders, who the majority of whom are white, are right there at the table with us.
Thank you for that. And to close this out, I would just like to ask the panel, we started this by looking at Unequal Treatment, came out 20 years ago. We're now in 2022. Do we need to have a part two, a second, installment of the report? And I'll direct that towards you, Carolina.
Absolutely. I think keeping it first and foremost in certainly up front and from many levels. To me, the part two is, what have we done about it, and how have we integrated the different recommendations? Because I dusted off the book after 20 years. Those recommendations are still very much there. Our class standards are available. It is, what are our different, not just academic institutions, but our health systems that really drive much of the priorities in medicine? What are they doing about it? How many underrepresented minorities, do they have at their C-suite level? Do they have, certainly as physicians, are they working in these underserved areas, et cetera? I think the next stage is, what have we done and where are we going from here?
And with that, we've come to the close of our panel. Thank you all so much. And we want to continue the conversation, so feel free to ask any of us any questions afterwards. Thank you, and enjoy the rest of the Aspen Festival.